So right now we're gonna hear from Steve Klauser an overview of the 2 days, and then we're gonna break up and have discussion at the tables. When we break up for the discussion at the tables, look around. We want to have at least 4 people at a table for a discussion. So if you're in a table with less than 4 people, redistribute yourself. Move among the tables and redistribute so that we make sure there's a good group of people at each table. So we're going to start now with Steve Klauser. Again, thanks for your patience and your perseverance. We went through a lot of papers this morning quickly, a lot of key issues and a lot of implications for how the world in which we practice and the world in which we study and understand healthcare is going to be affected. I think Dick Scott's comment yesterday about the permeability of the field and the environment and the borders is a critical comment. It was really helpful in thinking about the challenges that we're facing in genomic and biomarker delivery. That the sale of things is faster than our actual understanding of how to use the information. So I think that we are seeing some really important concepts, and we're looking forward to pulling these pieces together. Steve Klauser, my colleague and co-chair of this effort, is a chief of the Outcomes Research Branch of the Applied Research Program, where he directs the National Cancer Institute's research program in outcomes research and quality of care. His research interests are in the development and implementation of performance measurement of cancer care delivery, patient-centered communication, health-related quality of life, and patient experience of cancer, and the evaluation of cancer care delivery programs. Dr. Klauser has worked for the Centers for Medicare and Medicaid, the Department of Defense, the American Medical Association, and McGraw-Hill in a variety of health policy research positions. He received his BA from the Michigan State University and his PhD from the University of Minnesota. So we've asked Steve to think a little bit about what's happened overall in these papers and how the pieces fit together. So Steve, take it away.
Thank you very much. Okay, the paper I'm going to talk about, quite frankly, is not quite a paper yet. We're a little bit more upstream than a number of the papers that have been developed so far, because we really were going to hold back a little bit and take maximum value of this conference and trying to really integrate the theme. So most of what I'm going to talk about is really a reflection of the papers, although I am going to take some time here to reflect on some of the commentary we've had over the last 2 days. And so since the paper isn't written yet, I must acknowledge my co-authors, because they're going to be very busy with me over the course of the next few weeks to get going and figure out how we incorporate all the tremendous information and input we've gotten at this meeting today. Well, I want to start where I think Steve started yesterday in his presentation, to emphasize that, this whole research initiative, particularly for the National Cancer Institute, is really instrumental in purpose. We're trying to improve cancer care delivery, and we're trying to do it throughout the continuum of care. And I think the good news is, which we may not have given as much attention to in this meeting, is that there is much to build on with intervention research in cancer, because we have made progress in building an intervention science that has contributed to smoking rates declining, screening rates increasing, and for some cancer, survival actually improving. But I think for many, the progress is just considered too slow. And one of the things I think that's frustrated us, and we've mentioned several times at this conference, is that journals tend not to publish our failures. So it's really missing an opportunity of a learning source for us to figure out how to do this better. And results, when we have them, are often mixed, especially when we take something that's successful and begin putting it in a different context. And third, performance itself doesn't always persist. That is, sustaining improvement is often a challenge in cancer care delivery. So I think one thing we were trying to do is begin to think about multi-level research as a way to broaden and deepen our understanding of intervention science and its potential for us to go beyond the patient and physician dyad to recognize, that there may be some other factors at play. And we do have learned in particular that, context matters. I mean, that word has probably been repeated more in the last 2 days than any other word that we've talked about. And we do have some experience with community-level mechanisms. Dick Warnicki pointed out in his presentation, Dick Stange pointed out particularly in areas of tobacco cessation. And I think we really are going to have to take a look at those. And even though those numbers of studies may be less than one hand, we should really mind them so we can learn from exactly what's happened in the community, so at least we can begin thinking about what we might do in the delivery system. But I think one thing we all agree is that two things that are particularly missing in these types of studies are organizational change mechanisms and national and state level policy mechanisms that really will drive potential, and as we heard in healthcare reform, may really drive the potential for changing the way providers and patients interact with one another in complex organizational settings. So we need to broaden our menu of intervention mechanisms beyond the patient and provider to look at those things that may either facilitate or inhibit change and improvement in care. And I think that what we've tried to argue over the past 2 days and discussed among ourselves here is that multi-level research does provide that opportunity. Obviously, it opens our eyes to intervention issues beyond the patient and provider that has been missing in many studies of this area. And it also provides a context to think about those kinds of factors which may be, in Brian's words, kind of mediators and moderators that allow us to look at the impact of those interventions in various ways through various levels in terms of their speeds of effect, their causal influences, and its direction or influence in sustaining these changes over time. But it also points to us to really think about context. And if there's one thing I think we can get out of the work we've done so far with multi-level interventions is that we have some messages to send to the people that are working in that single intervention arena, that we really do have to get more granular in defining context so that we can begin to build a science even within the single level intervention that will allow us to begin to look at how these multi-intervention systems might work. Now, I think that another thing we learned over the course of the last 2 days is that, this just isn't an intellectual exercise. I mean, cancer, as well as many other diseases represented by many of you out there, are really being hit by a double, what I would call, tsunami. Kelly Devers, talked about health reform and, how the major changes will hit both providers and health systems simultaneously at multiple levels over the course of the next couple years, whether it be coverage expansions and incentives that play out in terms of such things as performance measurement, payment reform, or coverage, and combining that with having to deal with these incentive effects in terms of these new kind of organizational entities called patient medical homes and accountable care organizations are really going to change in a very fundamental way, in a very complex way throughout the healthcare system, how patients and providers react to one another to try to produce the outcomes, with the potential, as Kelly noted, with a lot of potentially unintended effects. Also, we've learned that technological innovations such as e-health and the EHR also defines the way that consumers and providers will relate to one another in the cancer delivery space. But I do want to emphasize a point that Paul Cleary made about it provides an opportunity for us as researchers to think a little more non-traditionally about where we can get data, because through the internet, through other kinds of systems that are now being populated with this kind of information, it may allow us to get the kind of data that we believe we've been sorely missing, but we have to look for it in different ways. And of course, all this is playing out in a new environment where cost containment is even going to be enhanced as patients and purchasers look for value in services. And if that wasn't enough, Muin Curry then talks about the second tsunami, and that is genomic medicine and its impact on, holds for potential changes in the cancer care delivery system. And I think he made a good point about talking about the potential of these playing out at various levels in the system. But but even though it's upstream, it's clearly upstream, we've got to be thinking about starting to articulate those kinds of interventions to see, are they unique in genomics, or really can we draw from some of the other lessons we learned with other types of reforms that have come our way in the past? Well, I think another place that we start is when we think about kind of taking a look at this is, what have we learned? And this is data that comes from Marty Charnes and the tremendous work they've done to try to characterize the literature. And again, some of the take-home points that Marty made that I think are sobering for us is that, first of all, there's a very small reservoir of MLI research experience in cancer. I think as Marty said, that's 1 out of 5 intervention studies could even be considered multi-level intervention research. And it depends on even if you look at it by the intervention target or by unit of analysis. And again, some of us think that's pretty kind, because we're including both patient and provider interventions as multi-level intervention studies. And we keep coming back to that discussion of whether that's truly multi-level or not. And I think part of this reflects the fact that most quality of care research is really largely analytical in this area. It's not interventional. Interventional studies tend to be single intervention, single target, and most involve patients and caregivers. But I think we also have a lot of lacking of work in the cancer care continuum generally. That is, few studies examine diagnosis and treatment, surveillance and survivorship in cancer care. Most of the MLI work is in screening and prevention. Now, coincidentally, it's interesting that when we put out the call for proposals for poster abstracts, the abstracts we got really reflected some of the issues we've been dealing with throughout this conference. From our perspective, at least the abstracts, the way they read through, were actually what we would consider multi-level intervention studies according to our definition. And of course, when we reviewed them, we saw that there were many different uses of the terms of levels and interventions, which we talked about throughout this conference. But yet, I think if you go and look at the poster sessions and participate today at the reception, the potential to build multi-level intervention studies from some of these appear very promising. And so this is my last plug. Go visit the poster session at the conclusion of this conference. Now, clearly, one thing we have talked about is complexity of multi-level intervention research and the challenging nature of doing this kind of research. Talking to people throughout the day and at this meeting, and I think I came to the same conclusion that Paul Cleary observed in his remarks, that multi-level intervention research is not rare because it's considered irrelevant. It's just not conducted because it's so darn difficult, challenging, and sometimes expensive. And these are some of the main challenges that are noted by presenters and commenters that have been included during this session. And the first four really deal with some of the analytic and conceptual issues we had. But the last two point to the fact that there's also a cultural issue for us as researchers in terms of how we relate to one another in doing this kind of research and how we relate to our practice partners in making these kinds of studies happen. So what I'd like to do is just pose a few questions that I think may be a cross-cutting element of this kinds of research that maybe will be take-home messages for us to discuss further as we move forward. First of all, how can we use theory to guide assessment and selection of interventions? Several authors have mentioned that, theory should drive design, but rarely it's used to guide intervention strategies, and I would add unless it's in clinical effectiveness area where we have solid guidelines in cancer care, or to some extent in social psychology where we have very good elements. And it's not surprising because it's at the patient and provider where a lot of this research has been done. As we move into the organizational area, how do we think about evidence and what is an evidence in terms of thinking about an intervention? And these are really serious issues because if we define these interventions wrong, we can spend a lot of money with very little gain. And I think part of the problem refers to the fact that theories differ at different levels. This was mentioned. Psychological theory is usually emphasized when we talk about individuals. And when we talk about policy, it's usually economic theory that comes into play, but also at the organizational level. It could be organizational scientists, sociologists, and even industrial engineers that get into the game. And I think what makes it more difficult for us is that we tend to focus on what's familiar when we do this kind of research. Cancer researchers obviously are more familiar with biology and psychology, and I would add epidemiology, but less familiar with such things as management, organization, and implementation sciences. And we've kind of been cautiously optimistic in terms of this because we've been concerned that we really don't have a unified theory or conceptual framework that exists that includes all facets of multi-level research to show how these interventions at different levels simultaneously can influence the outcomes that we care about. And here where I thought it was very helpful to hear about the field research that Dick Scott talked about and the concept of families of theories that Maria Fernandez talked about. But I really would like to know more about that field theory because I really wonder if part of our problem, because of our focus, we are not taking advantage of some of the theories that we have today, such as the socio-ecological model. Now, In absent of that conceptual and theoretical framework, we have some other approaches and pathways we're talking about here. Brian Weiner talked about taking a practical approach, thinking very systematically and carefully about how these interactions interrelate with one another in terms of the target of interest, and then identifying those potential mediators and moderators. Alexander, of course, from a conceptual and theoretical level, also added timing as a major consideration. And the one point that I would like to talk about here is this issue of disease trajectory and status of cancer patients. Because one thing I've seen a little bit in this literature as it begins to evolve is that we're trying to look for a global answer that would apply to all cancers and looking how organizational interventions may make a difference. But it may be because cancer has it's a very complex disease, many different types, and you have to think about it in its stages and trajectories, that we might have to look at responses of specific cancers in patients at particular stages in order to get maximum value out of this. This adds yet another complexity to what we're doing, but I guarantee if we begin articulating it in this term, this will be more well received by study sections. Again, cautionary advice. Even though this is a team-based work, don't let a single discipline or stakeholder drive your decision, and researchers really need to engage both our intervention stakeholders with the research design process, and that really came through with Jano's discussion today. Now, another question. How do we measure the relative influence and interaction of interventions when used as a multi-level intervention package? Well, I think one thing I felt pretty comfortable with yesterday, that most people said that reductionist approaches that are looking for that silver bullet or looking for that silver bullet with a little bit of additive effect as we add things may not work as well in this particular field. Systems thinking may be much more fruitful, both in looking at the interaction effects of interventions as they're in place, but also that notion that was brought out by Alexander in terms of the importance of sequencing interventions. All that can be done and thought through in a systematic framework, and it may have give us another framework that we have to begin thinking about. This also has implications for research design. I think Paul Cleary and some others really talked about the important, we got to have comparison groups. I mean, there's no doubt about that. But the thing is that randomization may not be always feasible or best considering the dynamic nature of these multi-level interventions. That's a little uncomfortable for NIH and NCI, who has used the randomized design as the kind of sine qua non for learning about efficacy and effectiveness. Alternatively, now we're moving to a multi-method, qualitative and quantitative approach, and we're also begin to think about simulation modeling as maybe promising, either as complementary or a preliminary step to a larger study. I thought that was a very interesting approach, but I think, as others had mentioned, it assumes we have the data, because you've got to populate those parameters. But still, I think we all continue to come back to that factor as we think about these more advanced methodologies, whether it be structural equation modeling, whatever. Context of the intervention matters. And so we have to engage our stakeholders in order to get a clear sense of what that context is. Another question, what are the relevant methods for monitoring fidelity and sustainability in MLI studies? Multi-level intervention emphasizes, in my mind, from some of the discussions, have much more about effectiveness and scalability over efficacy and internal validity. And we're seeing a much more greater interest in pushing forward more flexible designs that evolve as interventions evolved. And trying to understand those issues of fidelity is very important, because we need to go on efficacy and scalability to look at things like generalizability and replicability. Those are issues that are fundamental tenets of science that we have to address in terms of this field if it's really going to take hold. We need to address implementation as much as execution. And in some instances, when we hear from Russ, it'll probably be maintenance as well, if we really want to understand how we can articulate the prospect of these interventions being sustainable. And I disagree with Elizabeth that sustainability is a myth. It's how we define sustainability in the context of these multi-level intervention studies that I think is important. It's not a static concept, it's got to be an evolving concept, and it's that underlying process which drives those changes. Those are the elements we need to continue to track in those systems as they evolve and change. Now, and I think everyone's mentioned that, this requires longitudinal design, multi-measurement points, including endpoints, I believe, after the study is completed, so we can go back and see how well these changes were sustained. Now, some of the other cross-cutting challenges are, we haven't talked about that much today because we don't get a lot of information on it, but, why do interventions fail, or if initially successful, become unsustainable? I think this is a very important question for us to think about too, because this is expensive research and we've got to do a very good job of picking those interventions right up front. Maybe we need some vital signs, for thinking about intervention design that not only will help us think about interventions, but also may create criteria for study sections and others to be able to make reasonable evaluations of the potential of these studies. Think about things such as failure to follow theory or the evidence. Again, I mentioned evidence in clinical effectiveness and in personal behavior, fairly well defined, but as we get into organizational interventions and policy interventions, we're going to have to think about how we articulate evidence in that way. Cochrane collaboration doesn't provide a lot of guidance necessarily on some of these measures. Failure to consider context. I think we've beat that one pretty much to death in the last 2 days. And a failure to consider benefits and the costs of these interventions. Feasibility is a major issue in terms of putting these things in real-world environments. And we really need to do much more work, I think, in the microcosting area to really understand what we're talking about in terms of sustainability. And failure, of course, to align incentives. Work like people like Sheila Leatherman shows that, you can come up, most quality improvement interventions fail because the business model of that organization becomes inconsistent with the kind of intervention strategy you have. You have to understand that business model or provide a new business model that makes sense for that organization to thrive and survive. And I would add on incentives, we need incentives for really good data collection, because this requires a lot of data, and I'll tell you, one of the biggest fatal flaws I see in many studies that are implemented is that there's not enough attention to good data collection, which is coming from many different kinds of sources. And one thing that I think my one addition to this effort over the last 2 days is I think we really are missing somebody. There's somebody missing in this room, and that's called the patient. We really need to think about including the patient as an active research partner, even as we think about moving upstream in the various level effects, because quality is not just about survival. It's also about improving patient-centered outcomes. And I think there's a risk that as we move up into the organizational level, we think that the patient somehow effect is going to disappear. But there's very strong evidence that that's not true. First of all, for example, the work that's been done by the Consumer Assessment of Health Plan Survey System shows that from a patient experience point of view, they can identify very specifically when a team is broken or when an organization is broken, and they do vote with their feet. And secondly, we've even done studies where we show even environmental design as an intervention can make a difference from a patient perspective. We did a study one time when we were trying to identify in chemotherapy suites why there was so much difference in terms of what was going on, and we did all the communication studies and all that. The intervention that made the difference was the integration of the patient care committee with the architectural design engineers that actually designed those suites in the first place. It was the biggest predictor. So that is an intervention that's done at the organizational level that's very patient-directed. Now, I think it's not surprising that over the last 2 days, a lot of the people that have been sitting up here have been people from the Department of Veteran Affairs. They have made major commitments, both in improving data collection as well as building practice-based resources that have been a major source of guidance for all of us that are getting involved in this field. And I think one of our questions is, should we build these platforms one at a time? Or do we build these platforms also from existing resources? And the only point I want to make is that there have been several references over the past days that we have many research platforms here at NCI that could be a potential to help launch this kind of research, whether they be modelers and statisticians, as Jeff noted in CISNET, or provider-based interventions such as Cancer Research Network and Comprehensive Cancer Centers, which, by the way, also bring the academic connection, as well as community cancer centers and others, population resources. We don't necessarily have to start this work from scratch in every instance. And finally, we also have some resources that allow us, if we can figure out how to do this and we can work across our division, I believe, to really build the capacity to move this field forward. We really need to work synergistically to build our MLI capacity based on our team-based science research that is now going on, both system science, transdisciplinary science, as well as participatory research, to begin to identify those key stakeholders and partners, which will create those learning communities for us to get this work going. And then we can take from what we talked about from Dick, shifting those organizational cultures and norms to try to provide the work for sustaining this kind of research actively at NCI. And that involves training and research, and of course social marketing to be able to define this kind of research clearly, both to the public but also to our boards of scientific advisors, and then follow from that the resource allocation that will facilitate this work. Well, I'm sorry, a day and a half that I haven't really closed all the questions, and we actually have more questions than answers. But I think it's really important in a field like this, it's relatively new for us here at NCI, that we got to start asking the questions, because we ask the wrong questions and get the wrong answers, we're really going to be in trouble. And I think one thing that I've also noted that, you know, it comes from words of a very famous basketball coach in college called John Wooden, and I apologize to all you UNC people out there that I didn't use Dean Smith. But people ask him, you know, when he was in his 90s, and he accomplished so much, 8 straight championships and everything, you know, why are you still doing this? Because he says, when you're through learning, you are through. And I think if we take that advice in terms of working on multi-level intervention research, you're likely to live a long life if you work with us. And also, the challenge is for us to figure out, can you also have a long and fruitful career in this work? And we're here to work with you to try to figure that out. Thank you.